Hello everyone. So we will be continuing with chapter 17, respiratory disorders of illustrated textbooks of pediatrics. So respiratory tract infection, lower respiratory tract infections are common in children. They include bronchitis, and pneumonia. About half of all cases are viral in origin. Around 1 in 3 children in the UK develop bronchiolitis during the first year of life. After 12 months of age, approximately 300 children per year will have a lower respiratory tract infection. First, bronchiolitis, the most common cause of serious respiratory infection of infancy, resulting in admission to hospital. Uh, 2 to 3% of all infants during number winter epidemics, 90% of ages 1 to 9 months, RSV, the pathogen, 80% of remainder are accounted by parainfluenza virus, salmonellovirus, adenovirus, influenza virus, human metapneumonia virus. There is evidence that co-infection with metapneumovirus, particularly RSV in human metapneumonia, may lead to a more severe illness, arises symptoms preceding cough and breathlessness. Because findings are shown in the figure 17.5. Feeding difficulty due to dyspnea is often the reason for admission to hospital. Recurrent apnea is a serious complication, especially in young infants, such as born prematurely, develop bronchopulmonary dysplasia, those with other underlying disease such as cystic fibrosis, or those who have a congenital heart disease and more at risk for severe bronchiolitis. Investigation decision to admit. Pulse ox should be oximetry should be performed on all children suspected bronchiolitis. No other investigations are routinely recommended, in particular chest X-ray or capillary blood cancers are only indicated if surgery is suspected. Hospital admission is indicated for any of this apnea observed or reported persistent oxygen saturation of less than 92 when breathing air, inadequate oral fluid intake less than 70% usual volume, severe respiratory distress, ranting, marked chest infection or respiratory rate over 70. Management is supportive, humidified oxygen delivered by nasal cannula or head box at a concentration adjusted according to the pulse ox. Infant is monitored for apnea. There is no evidential benefit from the use of mist nebulized hypertonic saline, antibiotics, corticosteroids, bronchodilators such as salbutamol and protropium. Fluids may need to be given by nasogastric tube or intravenously. The inflammation is hypoxic, despite standard nasal cannula oxygen heated, humidified high flow nasal cannula oxygen at rate of NaCO may be beneficial by allowing higher flows of oxygen delivered comfortably, although its role in bronchiolitis has not been determined. In some infants, non-invasive respiratory support with continuous positive air pressure CPAP or BiPAP or mechanical measures required. RSV is highly infectious and infection control measures, particularly good hand handling and cohort nursing and gowns and gloves have been shown to prevent cross-infection to other infants in hospital. Most infants recover from the acute infection in 2 weeks. However, as many as half will have recurrent episodes of cough and wheeze. Clearly, following adenovirus infection, illness may result in permanent damage to the airways, bronchiolitis, or nutrients. Prevention of bronchiolitis, monoclonal antibody to RSV, palivizumab, given monthly by intravascular injection, reduces the number of hospital admissions in high-risk preterm infants. Its use is limited by cost and the need for multiple injections. This is shown clinical feature of bronchiolitis. In an infant requiring hospital oxygen therapy has been given by nasal care, nasal tube for feeding, IV infusion, clinical feature of dry, dizzy cough, sinuses or pallor, tachypnea or tachycardia, subpostural intervascular recession, hyperinflation of chest, sternum prominent, delivered straight downward, and which are the signs of hyperinflation of chest, also shown in X-ray, auscultation, frying, and respiratory traps, and prolonged these causes of acute respiratory distress in an infant are bullet point is bronchiolitis, viral episodic wheeze, pneumonia, heart failure, foreign body anaphylaxis, pneumothorax, fluid effusion, metabolic acidosis, severe anemia. Now, next one is pneumonia. The incidence of pneumonia peaks in infancy and old age and relatively high in childhood. It's a major cause of child mortality in low and middle income countries, and more than 600 children die each year from pneumonia worldwide. Viruses are the most common cause in young children beyond the neonatal period, whereas bacteria are more common in neonates and older children. In clinical practice, it's difficult to distinguish between viral and bacterial pneumonia, and in more than half of cause, no positive pathogen is identified. The likely pathogen varies according to age, newborn, organisms of the genital tract, particularly group B, but also gram-negative enterococci and bacilli. Infants and young children, respiratory virus (RSV) are the commonest bacterial infections such as strep pneumoniae, influenza, Staph aureus, Bordetella pertussis, and chlamydia. Trichomonas are also cause pneumonia at this age. And children over 5 years, mycoplasma pneumonia, strep pneumoniae, and chlamydia pneumonia are the main causes. But all ages, mycobacterial tuberculosis should be considered. Immunization, which Asian influenza type B and pneumococcal vaccines has markedly reduced incidence of pneumonia from Asian influenza in recent separated pneumonia. Clinical investigations, fever, cough, and shortness of breath are the most common presenting symptoms. They're usually preceded by a upper respiratory tract infection. Other symptoms include lethargy, cold breathing, and feeling unwell. Some children do not have a gut presentation, localized chest, abdominal, neck pain, essential irritation. Examination reveals cytopenia and increased for gut breathing. The most sensitive clinical sign of pneumonia is raised respiratory, so this must always be measured in a febrile size. Classic sign of consolidation, localized illness, and percussion. Decreased breath sounds, rapid breathing, and respiratory post tracheals. Although these signs are often absent in young children, percussion will be stony dull. If there is an accompanying effusion and pyema, oxygen saturation will decrease. Chest X-rays only necessary if there's doubt about the diagnosis. Neither chest X-ray nor blood test include full blood count and acute phase reactions are able to reliably differentiate between viral and bacterial cause. When the pneumonia is associated with a effusion, this is initially sterile parapneumonic effusion but can become infected in pyema. When this happens, the fluid becomes increasingly viscous and fibrins transform, leading to septations. Management evidence-based guidelines for the management of pneumonia in childhood have been published. British Thoracic Society. And first, we see the chest X-rays and pneumonia, the dietary recipients of pneumonia in different lobes of lungs, diagram showing the horizontal fissures, and shading illustrates the key fanning in each lobe or consolidation. Right lower lobe, number A is right upper lobe. So there's pneumonia right upper lobe, consolidation right upper lobe with loss of volume of this lobe. The horizontal fissure has been shifted. Horizontal fissure has been shifted upwards. B is left lower lobe, left lower lobe is left lower lobe. Sorry, B is left upper lobe consolidation. C is right lower lobe consolidation with volume loss on the right, and the heart silhouette is clearly seen, but the right hemidiaphragm is raised and partially obscured. And a normal D is a normal right hemidiaphragm but partial loss of right heart border, typically of right middle lobe consolidation. Now, the E is left lower lobe consolidation. Diaphragm is not really seen behind the cardiac silhouette. And F1 is the lingular consolidation of this loss of left right border. Most affected children can be managed at home, but indication for admission includes oxygen less than 92, recurrent apnea, grunting, and our inability to maintain adequate food feed intake. During supportive care for children required admission should include oxygen for hypoxia and analgesia for pain. IV fluid should be given if necessary to correct dehydration and maintain adequate hydration and sodium. Balanced physiotherapy has no proven role. The choice of antibiotic is determined by the child's age and severity of illness. Newborns require watch supplement in IV antibiotics. Most older infants can be managed with oral amoxicillin with broader spectrum antibiotics such as chlomoxiclave, reserved for complications of unresponsive pneumonia. For children over 5 years of age, either amoxicillin or an oral macrolide such as clindamycin is treatment of child. There is no advantage in giving IV rather than oral treatment, mild, moderate, and unless the child is vomiting. Small sterile parapneumonic effusion occurs in up to 1/3 of children with pneumonia and it usually involves 48 hours of antibiotics. No, you resolves once the pneumonia is treated. Persistent fever despite 48 hours of antibiotic in the child with a fusion suggests it has become infected. This is a plural empyema. The fluid becomes increasingly viscous and fibrous transform, leading septation drainage may be required. The percute placement of a small bore chest drain under ultrasound guidance with regular installation of a fibrinolytic agent to break down the fibrin strands is usually effective. Video assisted microscopic surgery or even tracheotomy or decortication is sometimes necessary in refractory cases. Prognosis follow-up is not required for a child with a simple pneumonia who makes full clinical recovery. Those with a lobar collapse or persistent symptoms should have a repeat chest X-ray after 4 to 6 weeks to confirm resolution, which we call treatment pneumonia. Even those with empyema make full recovery in high-income countries. And some ways commonly acquired pneumonia can be diagnosed clinically treated with oral antibiotic, fever, cough, and it may have sensitive but not specific features. Granting crackers or dull percussion, stony dull, note on the asphyxiation in a child with fever and cough and more specific indications. Hypoxia, recurrent apnea, grunting, and or inability to maintain adequate fluid or feed should prompt referral to hospital. Next one is whooping cough pertussis. This highly contagious viral infection is caused by Bordetella pertussis, which produces pertussin toxin. A related organism, Bordetella parapertussis, causes similar illness but does not produce pertussin toxin. The illness is usually milder and shorter. Pertussis is endemic with epidemic every few years after a week of coryza catarrhal phase. The child develops a characteristics paroxysmal or spasmodic cough, followed by a characteristic inspiratory whoop paroxysmal phase. Spasm cough are often worse at night and may culminate in vomiting, tussive vomiting. During a paroxysm, the child goes red or blue in the face and mucus force in the nose and mouth. The whoop may be absent in infants, but apnea is common at this age. Epistaxis and subconjunctival hemorrhage can occur due to vigorous coughing. The paroxysmal phase lasts up to 3 months. Symptoms gradually decrease. Convalescent phase, but may persist for many months. Complications such as ammonia, seizures, and bronchitis are uncommon. But there is still significant mortality, particularly in infants who have yet completed their primary vaccination at 4 months. Infants and young children suffering severe spasmodic cough or cyanotic attacks should be admitted to isolate from other children who have been infected early in the disease from culture of a per nasal swab. Although PCR polymerase reaction is more sensitive, it can also be diagnosed serologically. Courageously, there is a marked lymphocytosis more than 15 on the blood count. Although macrolide antibodies eradicate the organism, they decrease symptoms only if started during the catarrhal stage. Siblings, parents, and school contacts and risk and close contacts should receive macrolide prophylaxis. Unimmunized infant contacts should be vaccinated. Immunization reduces the risk of developing pertussis and severity of the disease if affected, but does not guarantee protection. The level of protection declines steadily during childhood in most cases and now in young people over 15 years old. Reimmunization of mothers during pregnancy is recommended in UK and a number of other countries as it reduces the risk of pertussis in the first few months of the infant's life when it is most dangerous. Now, some ways pertussis is caused by Bordetella pertussis. Pertussis not have followed by respiratory whoop and contain infants apnea rather than whoop, which is potentially dangerous. Diagnosis is usually clinical, is suggested by marked lymphocytosis in blood frame and confirmed by PCR or culture from a paranasal swab. The next one is asthma. Asthma is the most common chronic respiratory disorder in children. About 15% of children either process have asthma in the UK. Worldwide, there has been an increase in incidence of asthma over the last 40 years, but this has now plateaued in most high-income countries. Although symptoms of asthma can be readily controlled, most children is an important cause of school absence, restrictive activity, and anxiety for the child and family. There are still about 20 deaths from asthma in children and young people each year in the UK. Pathophysiology is given in picture. Clinical features. Asthma should be suspected. Let's see the pathophysiology first. Pathophysiology is like atopy and genetic predisposition with environmental triggers, which are upper respiratory tract infection, allergens, house dust mite, rat pollens, pets, smoking, active or passive pollution, chemical irritants, paint, and aerosols. all cause bronchial inflammation, edema, excessive mucus production, cellular infiltration, eosinophils, mast cell lymphocytes, which causes bronchial hyperresponsiveness, exaggerated twitchiness of to inhaled and physical stimuli, cold air and exercise, causes reversible airway narrowing, bronchial restriction, relief by salbutamol, improve airway inflammation, improve with inhaled steroids, and symptoms as wheeze, cough, breathlessness, and chest tightness. Asthma, clinical feature asthma is suspected in any child with wheezing or on more than one occasion, particularly if this person persists between, if this persists between viral illnesses, interval symptoms. What is meant by we should be classified as parents and children often mean something different from doctors demonstrating or describing the sound, whistling in their chest when your child breathes out can be helpful. Ideally, the presence of wheezes come from auscultation during an acute episode to distinguish it from transmitted upper respiratory noises, which are often loud, easy to hear in children. Asthmatic wheezing, the polyphonic, multiple pitch noise, as multiple airways of different sizes are affected. A chronic dry cough is common in children with asthma, but usually the only symptom. Key features associated with asthma in the history include wheeze, cough, and breathlessness, worse at night and in the early morning, wheeze and breathlessness with non-mild triggers, interval symptoms, symptoms between acute exacerbation, personal or family history of an atopic disease, positive response to asthma therapy. Once suspected, the pattern or phenotype should be further explored by asking how frequent are the symptoms, what triggers the symptoms, specifically are sport and general activities affected by the asthma, how often is sleep disturbed, how severe are the internal symptoms between exacerbations? How much stool has been missed to this asthma? Examination of the chest is usually normal between attacks and long-standing asthma. There may be hyperinflation of the chest and on auscultation and prolonged respiratory phase and zonal polyphonic musical respiratory wheeze. Onset of the disease in early childhood may result in Harrison-Sulci. Evidence of atopic should be sought by examination of nucleus of allergic rhinitis and the skin for eczema. Growth should be plotted, but is usually normal. The presence of a wet cough, productive of sputum, finger clubbing, or growth faltering suggests condition characterized by chronic infection with cystic fibrosis rather than asthma. The preschool child diagnosed asthma in preschool children is often difficult. Approximately half of all children wheeze at some time during the first 3 years of life, with two main patterns of wheezing, viral episodic wheezing, multiple trigger wheeze. The figure shows depression of the base of thorax associated with muscular insertion of the diaphragm, which is the Harrison-Sulci associated with chronic obstructive asthma during childhood from chronic increased vocal breathing. Now, the prevalence of these in children caused by major phenotype by age. Now, the viral episodic wheeze, most wheezing preschool children have viral episodic wheeze triggered by viral respiratory traction with no interval symptoms between episodes. It is thought to result from an abnormal immune response to viral infection causing inflammation, obstruction of the small airways. Risk factor includes maternal smoking during after pregnancy, prematurity, and male sex. A family history of asthma allergy is not a risk factor, but the family history of early viral wheezing is common. It usually resolves by 5 years of age, presumably from increased airway size, multiple trigger wheezing. Asthma, multiple trigger wheeze is usually a wheezy episode triggered by many stimuli, which can include viral infections, cold air, dust, animal dander, and exercise. A significant proportion have asthma. The presence of asthma risk factors increases the likelihood that the child has asthma and will benefit from asthma treatment, for example, salbutamol during acute events and inhaled steroids over longer periods. Risk factors are more than 3 episodes a year of cough and wheeze for more than 10 days with viral infections, cough and wheeze between episodes, laughter or excitement causing wheeze, allergic sensitization, eczema, food allergy, or family history of asthma. Investigation less than 5 years of age diagnosis of asthma is based on history, examination, response to treatment, specific investigation such as skin prick testing to identify sensitization. Inhaled inhalation may help determine the precise phenotype and determine whether changes to the child's environment might improve symptoms, and chest X-ray is not necessary unless other conditions need to be excluded. In children more than 5 years of age, diagnosis of untest investigation may include PFR, peak expected flow rate, measured with peak flow meters, which are simple to use, portable, and useful for severe measurements. And the child should fully inhale before placing the mouthpiece between their teeth and sealing tightly with their lips. A sharp, fast exhalation will provide an estimate of the maximum rate of exhalation, and this is achieved very early in exhalation. Usually, the first 0.2 seconds fully controlled asthma leads to increased variability in peak flow rate, with both diurnal variability, morning usually lower than evening, and day-to-day variability. Spirometry, a non-invasive measure of flow through the airways, larger than the bronchioles. It involves blowing out as hard and fast as possible for as long as possible to generate reliable results. Children must be able to fully expire whilst completing each test. This one measurement of the volume expired in the first second FEV1 and the total volume of expired air post 5%. Asthma classically produces obstructive spirometry in which FEV1 is reduced but FVC remains normal, resulting in FEV1 ratio FVC ratio less than 80. Children with mild to moderate asthma may have normal spirometry when well. The typical spirometry serves fully controlled asthma for after salbutamol, bronchodilator flow, volume leaks are given in black, and so which show severe obstruction with normal respiration shown in green. Black shows pre and then post valve. Bronchodilator irreversibility identified by showing improvement before and after a dose of inhaled bronchodilators by more than 20% PFR and more than 12% FEV1, exceed nitric oxide concentration, NO fractional inhaled nitric oxide. If available, the marker of airway inflammation is elevated in untreated asthma and allergic rhinitis, recommended by NICE and helpful test and diagnosis of asthma children if there is diagnostic uncertainty. DD is diagnosis, small number of children persistent